Good evening, everyone. Can you hear me? Yes, it sounds good. Welcome. This is going to be a wonderful evening, isn't it? You can feel it. This is Making Global Impact Through Education and World Health. It's going to be so much fun. I'm Aggie Hirschberg, President of Women in Philanthropy. And for some of you guys that want to know what Women in Philanthropy is, it's very simple. About 22 years ago, a handful of ladies sat down and carved out a set of bylaws that we continue to follow today. And by set, I mean maybe 10 or 12 ladies. 22 years later, we have 1,800 members. And I want to say we have raised over $500 million in access for various parts of the campus. So the group more or less inspires women's giving across the campus and all walks, basically wherever we are needed. Many of our members work on with various advisory boards and serve on the UCLA Foundation as well. Basically, we identify needs and support that with all of our heart and passion, and we love what we do, and we love UCLA. So this event tonight is a collaboration between us, Women in Philanthropy, and the UCLA Center for World Health. I read so much about each. First of all, I have listened to many of you and read a little bit about the vision, but I felt that it was to heal humankind through shared knowledge and compassion, and to make a difference in people's lives throughout the entire world. I also learned that the Center for World Health is working with our UCLA medical students on this project, which will make a huge difference for these young people to start their life with a brand new system. It is my pleasure to introduce Dr. Tom Coates. He's going to be telling us all sorts of details. Dr. Coates will be sharing all the information about the UCLA Center for World Health, which advances the international and global health mission of the David Geffen School of Medicine at UCLA, and whose motto is saving lives and improving health by investing in people. Dr. Coates is the director of UCLA Center for World Health and also co-director of the University of California Global Health Institute, which advances the mission of 10 campuses of the UC system to improve the lives of people not only in California but around the world. His areas of emphasis are global health, HIV prevention, and its the relationship to treatment of HIV, and international health policy. He is a Michael and Sue Steinberg Endowed Professor of Global AIDS Research within the Division of Infectious Diseases. Please help me give a warm welcome to Dr. Coates.
Thank you, Aggie, and thanks to all of you for being here tonight and hearing our stories so that we can share what we do. Thank you to Women in Philanthropy for hosting us tonight. We're really pleased that you're here. We are very passionate about what we do. We care a lot about what we do, and we want to share some of those stories with you. You might wonder why we chose the motto that we did, saving lives and improving health by investing in people. You know, it's the people of the world that are going to save the world. And it's UCLA can't save the world. We can't save the world from here. We can pick a spot or a few spots and make a difference. And the way we make a difference is by helping people on the front lines of medical care around the world do a better job of what they do. And that's our goal here. Our goal is to really change the face of healthcare around the world. Now we work, all the blue is where we work. And we work in lots of different places. And as you can see, we United States, Canada, Brazil, Russia, China, India, Australia, down the east coast of sub-Saharan Africa. And that's why we call ourselves the Center for World Health. That is, we're interested in the whole world. There's something to teach and there's something to learn, no matter where we go. Now, there's a quote I want to read to you. This is from John Greenleaf Whittier, the Quaker poet. And he said, "Of all sad words of tongue or pen, the saddest are these, it might have been." Take you back to this little boy from Peru. What might he be possible? What might be possible for him if he has good health, if he has good health care, if he has a chance at an education? He could become the next doctor. He could save thousands of lives. And that's our mission. So tonight, I'm going to talk to you about, as I say, we work in lots of different places. Every place we work, there's inequity. Some people are better off, and some people are worse off. And that is really true of the world. And so tonight, we're going to talk about our activities in the poorest parts of the world. Now, you're all used to hearing stories about how the world is going to hell in a handbasket. We're going to give you hope tonight, because the spots we've picked and the actions we're doing really do make a difference. I'm pleased to introduce our panel, beginning all the way over on your left. That's Dr. Dan D Ugarte. He's an associate clinical professor of surgery in the Division of Pediatric Surgery and is a co-director of the Global Health Education Program at UCLA. Next is Dr. Lee Miller. Dr. Miller is a professor of pediatrics. He is probably the most honored teacher in David Geffen School of Medicine. He's an incredible teacher. He's also the Associate Dean of Student Affairs in the David Geffen School of Medicine and the director of our Global Health Education programs. Next is my boss, Dr. Judith Courier. She is the chief of the Division of Infectious Diseases, associate director of the UCLA Clinical AIDS Research and Education Center. She's also the co-chair of an NIH-funded worldwide network to do AIDS clinical trials research. Next is Dr. Chris Timchuk. He's an assistant clinical professor of medicine in the Division of Infectious Diseases and General Internal Medicine, and he's the director of the Global Health Pathway in the Department of Medicine. And finally, I'd like to introduce Dr. Fulla May, the moderator for this evening. She's an assistant professor of medicine. She joined the faculty almost a year ago, and it's been a great year for us. And she's in the Division of Digestive Diseases. She's also a co-director of the Global Health Education Programs, and she will be this evening's moderator. Thank you very much.
Well, I want to thank you, Dr. Coates, for the introductions, and I want to thank and welcome everyone for being here with us this evening. We're going to spend a few moments with each panelist to learn about the work that they do here at UCLA and at the different divisions and departments in which they work. I'm going to start off with Dr. Christopher Timchuk. As Dr. Coates mentioned, Dr. Timchuk works in infectious diseases and also in general internal medicine here at UCLA. Currently, he is the director of the Global Health Pathway, which is an opportunity for our internal medicine trainees. And Chris will tell us a little bit about that program and what it offers.
Thank you very much, Fola. Can you hear me okay? Advance this. Oh, one back. So thank you very much for having us tonight. It's an honor to be here on the panel. I'm here to tell you a bit about the Global Health Pathway that I help oversee in the Department of Medicine at UCLA. And the main goals of the Global Health Pathway are to help train physicians to be able to work and care for patients in resource-limited settings, whether it's in the United States or abroad. And we also help to train physicians who are in our partner sites in resource-limited settings. Our main partner sites are in Malawi, which you'll hear more about throughout today, or this evening, and then Peru as well. And these are some examples of trainees that we have, doctors who have participated in our training and have gone abroad. They have all helped to participate in training the local clinicians abroad, as well as caring for patients in Malawi and Peru. We send 25 trainees abroad each year, and over the past 4 years that the pathway has been in existence, we've had over 100 trainees participate in the training program. Again, some of the issues that they'll come across when they're abroad in places like Malawi are novel to them. HIV, tuberculosis, malaria, other tropical medicines like dengue, leptospirosis, rare tropical infections that they may not see here in the United States, but gain practice with caring for in our partner sites. Interestingly, they are also starting to care for illnesses that are more common in the United States, becoming increasingly prevalent in our partner sites, including hypertension, diabetes, heart disease, cancer, which are very important in the resource-limited setting as well. So just to tell you the stories of these physicians, I'll start here with Dr. Faisal Saab, who is a senior medicine pediatrics resident at UCLA, and he has been training in Malawi since 2012, and I've had the pleasure of working with him there since he was first a medical student in 2012, and I've seen him grow into a real leader in the global health field, and he plans to continue on working in global health as a chief resident, and then when he takes on his work as a hospitalist. So here he is with a young girl who we were caring for together, who had malaria, and she received treatment for malaria, had a complete recovery, and so Faisal at this point was teaching her about selfies, so he called this photo Selfie After Beating Malaria. So fantastic photo of him, and that sort of encapsulates his personality. The other photos we have with him are doing yoga with the local clinicians and other great photos. The other person here is Dr. Kristen Schwab. She is a senior medicine trainee as well, and I've had the pleasure of working with her in Malawi over a 2-year period. The first time that she was there, she sort of had to get used to the novel experience, the resource-limited setting, but by the second time we went back, she was really sort of taking charge, taking a leadership role, and starting to teach some of the local medical students, including this student here, at a patient's bedside in the local government hospital. And she too is planning to incorporate global health in her career as she moves forward. Here on the bottom is Dr. Pete Paul, who is one of our faculty members who participated in training in Malawi as a resident and now has incorporated global health into his career. So as a faculty member, he's been traveling to Peru and has been teaching bedside ultrasound training in Peru. And this is a small handheld ultrasound machine. And he too continues to carry on global health in his career. And you can see Peruvian physicians resident and then a UCLA resident there as well. People were very enthusiastic to have this training. So as you can imagine, these experiences are very rewarding and sometimes transformative. And I actually just briefly wanted to read 2 confidential evaluations from participants in the training. One is that I truly believe I'm a better person and physician having had the opportunity to travel to Malawi and learn from such an inspirational group of physicians. The other quote is that this was the greatest thing I did in residency, possibly even in my life. So very rewarding and transformational experiences for our participants. These are photos of colleagues from Malawi. And when I think of our colleagues in Malawi, the quote by Abraham Verghese comes to mind. And the quote is that geography is destiny. And it's particularly important for colleagues in resource-limited settings that if they were in the United States, they would very likely be able to become physicians. But it's very challenging in resource-limited settings where there's few spots for them to train. It's very expensive for them to train as well, for them to go on and become physicians. This is important for one of our most beloved colleagues, Levison, who is extremely intelligent, hardworking, outstanding clinician, and universally loved by all of the UCLA doctors who work with him. Unfortunately, he has not been able to get into medical school, or was not able to get into medical school initially because of limited spots, the cost, but we have recently learned that he's actually been accepted into medical school in Kenya, and we're all very, very excited about that opportunity. Here is Dr. Dan Namarika, who is the medical director of Partners in Hope in Malawi, where we work. and he is an outstanding clinician. He was actually the former president's personal physician, and we try to embrace a bilateral relationship with our partner sites. So we host physicians from these countries at UCLA. His visit here was fantastic. Everybody loved having him here. He learned a lot, we learned a lot from him, and it was amazing to watch him teach our medical students about medical care in Malawi. The last photo is here of William. He's actually a Malawi medical student that I helped to train a little bit while I was there last time in Malawi with one of the other UCLA physicians. And we in particular trained him how to listen to heart sounds. And he was very astute at this, very adept, and really appreciated our teaching. And he recently sent me an email thanking us for our training, and I just wanted to read this to you. Hi, Dr. Timchuk. Today in the morning, I picked up a murmur in a 10-year-old girl. I was able to make a diagnosis of mitral regurgitation secondary to rheumatic heart disease, so a common illness in the developing world. Thank you so much, Dr. Timchuk. Thank you so much, UCLA. I will fly high like an eagle in my journey of becoming a medical doctor. It's a great quote from this medical student. So ultimately, all of the work that we're doing is about improving the lives and patient care of the people in the parts of the world that need it the most. And I'm going to share the story of this young man with you, and I have his permission and his mother's permission to tell the story here today and use his photo. He's a 16-year-old man, young man, who we cared for at the local government hospital. He came into hospital very sick, fevers, headache, over several weeks, became even more sick, had trouble walking, talking, couldn't even feed himself, and finally his mother had to bring him into hospital. So along with the local colleagues, we tried to figure out what was going on with him. Was it a complication from HIV? Was it TB, malaria, bacterial meningitis? And ultimately we were able to diagnose him with bacterial meningitis. And this is a potentially deadly illness if it's not properly treated. It can result in deafness, blindness, seizures, and ultimately potentially death. Unfortunately, the hospital didn't have the medicine there, and the family couldn't afford the medication. Thankfully, we were actually able to obtain the medicine for him, treat him with it, and he made a complete recovery and was able to return home to his village without any complications. And the amazing part of that is that the cost of the medication for a 2-week supply was only $50 US. And that's not a copay, that's the entire cost for the medication. So, that's one of the success stories that we've had, and it's very close to me. It's a very important story for me. So just to remind you that the reasons we're doing this, the goals of the program are to train physicians to work in resource-limited settings, have those physicians train physicians who require additional medical education, and then care for patients directly. Thank you.
Thank you. Thank you, Dr. Timchuk. One of the things I'll ask you now is if you could share with us a little bit the vision of the future of the program, or what you envision for the future of the training program.
It's a great question, and thank you. I think that we would like to sort of continue expanding the great work that we're doing, both in the countries where we already work, and then to expand to other locations. We're already looking at a potential site in Thailand and establishing relationships there based on existing UCLA relationships. The other is actually building on the theme that we don't necessarily need to go internationally to help people in resource-limited settings. We can work within the United States. So we're looking at developing a relationship at an Indian Health Services site as well. And then ultimately, we'd like to develop a training fellowship that would allow these physicians to have 1 year of dedicated practice in a resource-limited setting rather than weeks or months at a time.
Fantastic. Thank you. So I'm now going to pass this to Dr. Judith Courier. Dr. Courier is the Chief of Infectious Diseases here at UCLA, and she's going to share with us some of the research that she does in HIV in Malawi.
Thank you. It's really great to be here. Thank you all for coming. So I'm an AIDS doctor and a researcher, and I've been doing this for about 30 years. And thinking back to the beginning, when I was a resident in the 1980s in Boston, HIV was a new disease, and young people were being diagnosed and dying without us being able to really do anything. And I was trying to figure out what to do with my career as an internal medicine resident. And I thought, well, this is pretty obvious. They need people to work on this. And I decided I wanted to be involved in AIDS, and I wanted to be involved in AIDS research to try to figure out how to treat HIV. And as I think back to what influenced me the most at that time, there was a young faculty member who had just been recruited to Beth Israel, the hospital I was working at, who had been at the NIH. And she was so smart and really knew about what was going on with HIV. And I looked at her and I said, I want to be like you when I grow up. This is what I want to do. And so I got involved in this group called the AIDS Clinical Trials Group and was able to participate in studies for treatments of HIV. And I've been doing it ever since. And we've gone from having a disease that's untreatable to one where you can take one pill once a day. Oops, I forgot to put my first slide up. And live almost normal lifespan. And that's been achieved through research. So I'm really committed to using research as a way of improving global health and inspiring and hopefully mentoring people who want to have research careers. I'll try that. Okay. So I've worked in the AIDS Clinical Trials Group, as it was said. We now have 59 sites in 12 countries and do studies on both antiviral therapy, tuberculosis, hepatitis C, and actually we're working on trying to find a cure for HIV. But I've also been working specifically in Malawi through a grant that was funded over 5 years ago from the US government under Tom's leadership. And this was a program it's called EQUIP, for expanding or extending quality improvement in Malawi. And the goals of this project are to improve or strengthen the health system, to mentor and train clinicians in providing care, and to do some practical operational research at the sites. This has been an extraordinary experience to see Malawi roll out antiretroviral therapy and to look as you drive through the streets of Lilongwe and see the transformation of a place where all they were selling were coffins to now all they're building is furniture. This is our EQUIP research group, and on the right-hand side is Kumbo Viri. She's one of our Malawian colleagues who's been bitten by the research bug, and she's working with us. So this is her presenting some of her work on understanding why pregnant women in Malawi stop taking their medications after delivery. She's presenting this at a conference. So the places that we work are pretty challenging here, in addition to just logistics with power, electricity, or lack of electricity. The infrastructure for conducting research is also somewhat strained. It takes a long time to get IRB approval in Malawi. We have to go stand outside the door of the place and basically negotiate to have a meeting so they can review the proposal. But when everything comes together, it still works, and the effort is really worth it. This is an antiretroviral therapy clinic in Malawi, and a clinician there who's preparing for the day. And in these sites, even though they really look like they have nothing, they have such limited infrastructure, it's incredible what can be accomplished in terms of both treatment and conducting research. And this is something that was just not thought to be feasible 15 years ago. Now we offer treatments being provided and rolled out globally, and in places like Malawi, where people are diagnosed with HIV, they take one pill once a day and they return to a healthy life. Pregnant women are also able to take the same medication and prevent the transmission of the virus to their baby and have healthy families and live normal lives. This is unimaginable when I first started out. It's been an incredible experience for me to be at UCLA. When Tom mentioned, UCLA invests in people, he's absolutely right. And those investments pay off by being able to develop programs and mentor others and teach them to continue this kind of work. And I think it's really exciting to think of what can be accomplished with HIV we have the tools to put an end to the HIV epidemic. We just need the resources and the commitment to make it happen. And the example of HIV, I think, is also inspiring for other global health problems, because it's not just about HIV, it's about tuberculosis, malaria, and treatment for chronic non-communicable diseases. But this model, I think, can be translated into many other things. And so with devoted people and resources, really anything is possible. So thank you.
Thank you, Dr. Courier. As a woman in science, you probably note that there is a big gender disparity with less women pursuing research, especially in global health. Can you tell us how you think we can better support women pursuing research in global health?
Yeah, that's a great question. And I think as I look back, there's just no substitute for mentorship. Providing opportunities for people to have dedicated time for training and maybe a little bit more time. I think it's particularly challenging in global health. A lot of people want to do global health, but they want to live in the United States, and they want to, they're trying to think about how you're going to start a family and be going back and forth to a place like Malawi and living in a place where you may not want to be raising your family. It's really, really challenging. So I think that really dedicated resources for fellowship training in infectious diseases, global health, and also allowing people just a little more time to figure out how to get through all this at this point in their life when they have lots of competing demands.
Thank you. So next we have Dr. Lee Miller. Dr. Miller is the Associate Dean for Student Affairs at the David Geffen School of Medicine. And he also is the founder for Partners for Pediatric Progress. Thank you, Dr. Miller.
Thanks. Thank you, Fola. Thank you all so much for this opportunity this evening, and it's an absolute treat to be able to share with you programs about which we're so passionate. I've been at UCLA for almost 30 years. And over this period, my professional passions have been related to children's health, to medical education, and to global health. In the middle of this period, I had a sabbatical with the World Health Organization and lived in Switzerland and spent much of my time on a sabbatical in Africa, and subsequently worked in Rwanda during the Civil War and in Afghanistan. And I came back from these experiences really committed to nurturing opportunities for the next generation of physicians and public health leaders. So with these interests, about 8 years ago, I began to explore ways in which I could combine my interests in children's health, medical education, global health, and the product of that is really Partners for Pediatric Progress, or P3 for short. And this is a nonprofit project that establishes training partnerships in super low resource settings, and the goal is to improve the care that's provided to children in the local setting. And while we do some clinical work in this capacity, the model is really to build local capacity. It's the ultimate teach them how to fish rather than fishing for them. And I'm essentially a medical matchmaker. I'll tell you a little bit about how I do this, but these are our two training sites. Our main site is in Mozambique, and that's a very long coastline, and we don't have the whole world scale, but that east coast of Mozambique is actually longer than the east coast of the United States, the west coast of the United States. It's longer than San Diego to Seattle, and it's quite a beautiful coastline. And our other site is in northern Peru, in the Amazon region of Quitos. And I want to give you a feel, just a little bit of perspective on the degree of disparities in some of the places in which we've chosen to work. When I first started working in Mozambique 8 years ago, there are 10 million kids. There are now almost 11 million children. There are only 10 pediatricians, Mozambican pediatricians, in the entire country. Incredible ratio. There were clearly no pediatric subspecialists. There were no pediatric surgeons. There were 2 pediatric ventilators for the 10 million kids. And I can go on and on with other examples. So I mentioned that I'm a a medical matchmaker, in that we go into these partner sites and meet with the leadership, head of pediatrics, the leaders of the School of Medicine, the Ministry of Health, to identify what the greatest priorities are for the setting. The reason I said I'm a matchmaker is that I'll come back to UCLA, and having done that needs assessment, will help identify teams of clinician educators who will in turn start working in these partner sites to build the capacity of the local healthcare workers, of both the physicians and nurses. We have folks traveling in both directions. We have faculty members and nurses going to Mozambique and Peru, and we have the leadership and healthcare providers from Mozambique coming to UCLA as well. When I first got to Mozambique, they identified the major priorities as improving newborn care, improving pediatric critical care, and improving the care of pediatric surgery. And in just a few minutes, Dan will share more with you about the work that he has done to really dramatically turn around the surgical care of children in the country. But since those early years when we started in newborn care, critical care, and surgery, we've expanded greatly. We have a very important project in hospital infection control to decrease the number of infections in the hospital, which is, these are enormous numbers. We're doing pediatric nephrology training, pediatric radiology, pediatric pulmonology, and pediatric cardiology. As an example of how some very basic interventions can have a huge impact, when we first got to the teaching hospital, the newborn mortality in the Mecca main academic teaching hospital was 32%. So imagine a nursery, the referral teaching hospital, where 1 in 3 babies does not make it out of the nursery. This is a 1,500 bed hospital, so about 4 times the size of this building, with an average daily census of 3,000 patients. So the kids, the babies, are doubled up, 2 in a bed or on the floor. So by introducing some very basic hand washing protocols and introducing infant warming techniques, the morbidity and mortality started going down dramatically. And we helped contribute to the mortality going down to 18%. Now, that's still 1 out of 5 newborns who are never reaching their homes. And we certainly have a great deal of work to do, but I think this is a powerful example of the way that simple interventions can have a real impact on the lives of others. We're also very fortunate now to have a superstar American pediatrician who's a UCLA faculty member who is now based in Mozambique, overseeing the program, thanks to really the generosity of folks who have supported our program. Now, I also want to give you a quick feel for one of our other partner sites. This is in Iquitos, which is the main city in the Amazon region of Peru. This is good New York Times trivia. Iquitos has been described as the densest city in the world with no road access. It's an island city that's only accessible by boat and plane. And the medical community in this city of Iquitos serves not only this urban slum city, but the whole northern portion of the country. So there are about 500,000 people who live on this island, and another 500,000 people who live in rural jungle. And some of the children for whom we care in Iquitos live in very remote villages with small branches and tributaries of the Amazon, and they travel by boat for over 2 weeks to get to medical attention. This image is from the community of Belén, and we've been working in a clinic in the middle of Belén that is only accessible by this intricate network of planks. And for about 4 months of the year during the rainy season, when the Amazon waters rise, this is the only way that we could access the community. Now, finally, with the relationships that we've established, we have been able to use these partner sites to provide fantastic teaching sites for UCLA medical students and residents. Dan and I were both in Mozambique 3-4 weeks ago, and it was a real treat to be there with 2 senior medical students and 2 pediatric residents. And our trainees come to realize that global health really means addressing healthcare disparities in all settings. And it doesn't matter if it's sub-Saharan Africa, Latin America, Indian subcontinent, or our own backyards here at home. And I have no doubt, both anecdotally and from the literature, that our trainees come back from these experiences with more humanism, more cultural sensitivity, and a greater commitment to addressing healthcare disparities here in our own backyards. They're absolutely changed. So I really appreciate this opportunity to introduce you to the work that we're doing in these settings. Thank you.
So, Dr. Miller, as a dean in our medical school, you are uniquely invested in how we develop our medical students into medical doctors. Can you give us an example of how a trip to Mozambique or to Iquitos has impacted a student at David Geffen School of Medical School?
Well, I can give you a general answer and a specific example, but a fair number of our students who participated in these experiences have gone on to careers in global health, and they've made very dramatic contributions working for the CDC or other international organizations or joining academic medical communities. But there's a very powerful anecdote, a story that I want to share with you very briefly. Aggie may have heard this one before, I don't know, but one of our senior trainees was very skilled at critical care management. He had a lot of training working in an ICU setting, and he was working on a ward where 3 or 4 patients were dying every day. Here, as a pediatric resident, other than working in an ICU, I may have had a few, 3, 4 patients die over my 3 years of training outside of a critical care unit. There were 3 or 4 patients a day that were passing. And this resident was walking down the hall, and he saw a toddler that wasn't doing well. He called the local doctors over, and he started bagging the toddler with oxygen to try to bring this child back. Things were not going well. And he told the local team that the patient needs to be intubated, and that means putting a breathing tube in to support his respirations. And he asked them to get the equipment for the intubation. Around the same time, the child's heart stopped. So imagine this 22-year-old young new physician doing chest compressions on a toddler halfway around the world and bagging the patient to try to keep him alive. The team came running with the tray, and the tray includes a special flashlight on a hinge called a laryngoscope, and that is the piece of equipment that's used to look into the throat to get the breathing tube in the right place. And Ryan took the laryngoscope, he stopped chest compressions, flicked the flashlight, and it didn't work. Battery was dead. And Ryan said to the local doctors, please get me another battery. And they said, Ryan, we don't have batteries. So back to chest compressions and bagging, and this is incredibly bright young man. He said, get my backpack quickly, please. And in his backpack, he had a Sony Walkman, and he said, take the batteries out, and they were the same kind of batteries that go in the laryngoscope. So he put the batteries in the laryngoscope, and it worked. He stopped chest compressions. He got the tube in perfectly. The patient started to come back, and then he said to the team, please bring me the ventilator. I'll show you how to set it up so we can support this child. And they said, Ryan, we only have 2 ventilators in the country. One is broken, and the other one is being used. There was nothing to do for that child, and the only way to keep that child alive would be to bag this patient all through the day and night. There was no family members there, and there are literally scores of these kids on the pediatric wards who don't survive each night because there aren't enough ventilators to keep them going. So here's this 22-year-old young physician who decides that the best gift that he could give this child would be to let this child pass being loved. So he took the tube out, and he held the child in his arms, and the child died in his arms. It's a terrible example of healthcare disparities, but an incredibly powerful one. And imagine the indelibly imprinted lesson in this young physician's life from such a powerful experience. And this man has gone on to join the faculty of another medical school, and he's still doing international global health.
Thank you.
Sure.
So now I'd like to reintroduce Dr. Dan D Ugarte. Dr. D Ugarte is an associate clinical professor of surgery in the Department of Pediatric Surgery, and he's going to share about our training programs in Mozambique. Thank you.
Thanks so much for giving us the opportunity to share our experiences, and thank you to Dr. Lee Miller and Tom Coates and everybody at the UCLA Center for World Health. I was a medical student here 20 years ago and didn't have opportunities to engage in global health, and it's been so exciting for me to have trained here and to have seen really the program unveil itself, roll itself out, and provide these opportunities for students at UCLA. I had the good fortune 5 years ago of being invited by Dr. Miller to go to Mozambique and participate in the training of pediatric surgeons in Mozambique. There was only one general surgeon, native, who was responsible for the care of these 10 million kids. And thankfully, there was a very young, bright pediatric surgical trainee who I also had the opportunity to work with. And they are now the two native pediatric surgeons for the country, now training the next two pediatric surgeons. So this has been a great model of care that I've gotten very excited about in terms of partnership development. How can we help train the next generation of physicians? It's a model which, you know, I must admit, when I first got introduced to global surgery, I thought of surgical missions, and I didn't appreciate the concept, and there is definitely a role for it, going out and doing several operations and helping out a few kids. But how about the opportunity to go and train the surgeons that are going to then be able to year-round, lifelong train and treat future physicians and treat and care for patients? Well, our partnership has certainly grown and expanded, and there's been an increased recognition in global health that surgery is a very important element to public health and global health. It was coined the forgotten stepchild of public health. And the reality is that surgery is not that expensive. Maybe if you have it done here at UCLA and you have a very fancy procedure with a robot, but the bulk of surgeries across the world can be done for very little amount of money and have an incredible impact. In fact, if you do the public health metrics, the impact of surgery is just as cost effective as vaccinations. And so I think that's something that's underappreciated when thinking about global health. So my own experiences started out proctoring the local surgeons. So unlike many surgeons maybe who go and they just do the operation, my goal was always to be the trainer, to help observe, assist, facilitate, provide textbooks, pay for workshops, travel, bring surgeons here to the United States so they can experience not only how we do surgery, not all of it would be very relevant back home, but how to educate other trainees, how to work with a team, how to work with nurses. A lot of these things that we ourselves are just learning in our own healthcare system, how to improve quality of care. So, you know, this is a wonderful child to the far right. This is very illustrative of the experience. We had lined up 4 cases to be done that day, and the first patient that we brought into the operating room was undiagnosed with a very complex anorectal malformation, the details of which we don't need to go into. But I immediately recognized the situation after the patient was anesthetized. It was going to be an 6-hour case, and so we had to cancel all the other patients who were going to get rescheduled, and who knows when they were going to get done. But it was a great learning experience, both for me and for the young trainee, to go through this very challenging case. The reality is that one learns a lot being in these types of experience, patient selection, and how to be efficient with existing healthcare. But Vonda's been a great partner, and we've carried on beyond the clinical care to also start research training. So she's now investigating what are the cases that she's doing, how can we best utilize the local resources. There's a large number of burn patients that we don't see here in the US, largely probably due to the poverty locally. So what are the risk factors that contribute to the burns? What can be done on a public health level to prevent them? And how can we best manage the burns that do come in with the local available resources? So this is really spun off, and we've partnered with surgical mission groups like Mending Kids International, So now there are mission groups that are going out once or twice a year to help support burn training. For a long time, we had actually sent out multiple pediatric surgeons, because I can't go there every week and can't be there year-round, to help train the local surgeon. And essentially, they've graduated from those visits. And these types of stories are evident throughout some of our other partner sites with other surgeons in our faculty. There's a surgeon, a urogynecologist, who's doing work in treating obstetrical fistulas, and he's trained a whole cadre of local doctors to manage these so that he can then move on to the next site and train other doctors. The other really exciting thing that we're doing is, like the other programs, we've incorporated both students and trainees in our trips so that they can get early on exposure to how to develop sustainable partnerships and train the trainer programs and models. One of our colleagues, Dave Chen, has been working out throughout Latin America to train local surgeons how to do hernia surgery. So very basic operation that has such a dramatic improvement on the quality of life, but how do you do it right so that there's much less likelihood of a complication? And he has incorporated brilliantly technology with these GoPro devices to be able to telementor local surgeons on how to improve their surgical care. In addition, he's utilized local operative performance evaluations to give feedback to surgeons and graduate them from these workshops that he conducts. One of my colleagues, Dr. Shekardimian, is working in not necessarily low-income countries, but middle-income countries like Armenia, where he's able to help there's enough surgeons there, but what he's doing is he's improving the quality, decreasing the mortality rates from anesthesia, and making sure that the right operations are being done and that they're being done properly. So this global surgery initiative has really taken off, really due to the UCLA Center for World Health Support, and it's had just such incredible ripple effects at UCLA.
And Dr. D Ugarte, could you share with us what you think the key to success for the partnership in Mozambique is, and how we might replicate that in other parts of the world?
Yeah, I think identifying young, willing, eager partners who are willing to make changes, and there are obviously a lot of obstacles in making change locally. I think you need to have a real commitment on both sides. You know, we went into this really with a 5-year plan, and I think that 5-year plan will probably extend itself as we see young trainees coming out and needing a little more career development. So I think that's the key. A lot of patience and persistence as well.
Thank you. Thank you very much. And I'd like to thank all of our panelists for sharing their experience and their work with us this evening. Thank you guys all. And I've had the opportunity to ask some questions, but I'd like now to turn to the audience and give you all the opportunity to ask some questions of our panelists. I believe there are a few individuals that have microphones that can circulate them. Any questions from the audience? There's one question up here.
I can scream.
Okay. Actually, the microphone's right here because I think we'll catch you on the video better.
What discrepancies have you witnessed in education of the medical staff you're working with? Have you?
That's a loaded. So, I think Lee and I feel pretty strongly about this. It's a very alien for us to hear about some of the experiences of medical students and trainees in Mozambique. The pediatrician trainees having a very, what we call, malignant environment that's not very conducive to learning. It's a very stressful environment to work. Patients are dying left and right. There are a lot of demands. The salaries are low. It's tough. So what we try to do in our bilateral exchange program is bring the trainees here so they can see a different model. What we're trying to do is stop sort of the cycle of that abusive environment by providing trainees the exposure to what a more benign and benevolent and educationally conducive environment is.
Nurturing.
Nurturing.
Yeah.
Another question?
You mentioned telemonitoring or mentoring, and it seems to me that once you've met and established a relationship with these people overseas, that it's economical to get them the right equipment to receive information from you. I believe this one is a GoPro, but there's other ways of doing that might be huge in a program such as yours.
Well, we're certainly challenged by time zone differences and bandwidth differences. So this has been most successful in Latin America, where we don't have to, those barriers are somewhat reduced. The technology continues to evolve and improve, and there's some great potential there. I think one of the key things is just getting access to the medical literature. And so I think there's been some great progress made on an international level, enabling physicians from low-income settings to access the PubMed, is what we call it, the medical literature. And certainly now, all the textbooks are now available digitally for many of the physicians.
The hospital also didn't have internet access. There was no wireless. So one of the things that we did on our project was to put internet into the children's hospital so that the residents could have the opportunity to explore evidence-based practices.
And I think as well, you've experimented with shared conferences or thinking about shared conferences.
That's right. I think as part of our program, and a lot of us who are involved in this have conferences where we have people who are trainees in Peru or Malawi or Mozambique sharing interesting cases via teleconferencing with our trainees and sort of giving feedback and discussing things. This has happened with the pediatric side, the medicine side, and it's really been a fantastic experience. Again, the time zone makes it difficult sometimes working with Africa where it's 10 hours difference, but from Peru it's worked great. So we certainly take advantage of that.
So I know we have a couple questions up here, but I think in the back, you're first.
Hi.
Hi.
Am I working? Okay. Hi, my name's Kate, and I'm a social worker, so this is like breaking my heart. But anyway, I was just wondering, in terms of the local governments, how have they impeded your success or provided help in terms of, growing and building, hospitals and facilities to help all these people?
Well, I mean, I guess for the research side of things, it's really been a collaboration with the government in terms of providing, and for the program in Malawi that we do that's health system strengthening, it's really been a partnership with the government and the Ministry of Health and the district health officers. And it is a slow process, but I think they do see us as an important partner, and that's something that takes a while to establish, that having that consistency of going back and really showing results. So it's an ongoing challenge, though.
Any other examples of working with governments?
Yeah, it's been, we've had our share of challenges, changes in government, but we work very closely with the Centers for Disease Control, and the CDC is really our liaison, and they've helped facilitate opening doors. So we have had our program very well received and accepted by the Ministry of Health and the government, and in fact, they had to provide the final approval for the UCLA pediatrician to practice medicine and lead the program there. So it's with their blessing.
Thank you. Question?
Where does the funding for your various programs come from? And is it federal support, private philanthropy? And it would seem that almost everything that you're doing, from what you said, is scalable. In other words, if you had more, you could do more. Yeah. Could you address how you get more?
Yeah.
I think they're different for each. You want to start?
Sure. So the majority of the funding for my program comes through the Department of Medicine and the chair of the Department of Medicine, who's been very, very supportive of the work that we're doing. There's also some philanthropic work that sort of helps to support and expand what we're doing. And I think certainly it is definitely scalable, where if we had sort of And it would be sort of an exponential scalability, I think, that if we had a certain amount of input, we could have an exponential response to that.
The research funding comes from USAID and NIH, but it doesn't really cover everything. And especially for research training, which is something that we're really committed to doing. And so there are private sources of funding that help support and individual donors who underwrite some of the work. So it's really, it's like running a small business. I went into medicine thinking I was going to be a doctor and take care of patients, and I spend probably more of my time managing my portfolio of funding sources for all these activities, and I wish I had been better trained to do that.
Yeah, your question reminded me of something that I neglected to say, and that is all of the physicians that we're sending from here, from UCLA, are volunteering their time, and we're very grateful to the leadership of Mattel Children's Hospital to allow the faculty members to go. Dr. DeVascar has been very, very supportive. As far as actual funding the program, there are three major sources of support. One is from the U.S. government. Thanks to the Centers for Disease Control, we've been able to get a grant each year using PEPFAR funds. PEPFAR funds, that's the President's Emergency Plan for AIDS Relief. And they provide basic funding for some of the bi-directional trips of faculty members from there coming here and UCLA faculty members going there. We have a relationship with one company in particular, where we've tapped into their corporate social responsibility because they're doing business in Mozambique. So they've been very, very supportive for a few years. And then a very significant chunk of our work is really thanks to philanthropy from individual donors. All the work that we're doing in Peru comes from individual donors, and much of the work that we're doing in Mozambique. Chris Buck is the faculty member I mentioned who is based in Mozambique, a UCLA person, and Chris's salary all comes from individual donors. We found that we did these training trips and we would make 2 giant steps forward and we would leave and a couple of steps backwards, and then we'd go again, and the slope was like this. And then we found that if we had an in-country person, it just went logarithmically up. So he's really a superstar, and he also takes wonderful care of our UCLA students and residents when we're there. He's a fantastic teacher, role model, and he's had a dramatic impact on both the care and training in the setting.
And with surgery, remember I mentioned it was the forgotten stepchild of global health. So historically, most people have funded surgical missions with philanthropy. And it's very easy to say, well, we operated on 10 kids and it's $1,000 per operation. Our metrics are very different. How many surgeons did we train? What kind of impact are we having on the delivery of surgery across the population? How are we influencing people's training and education of other surgeons? I think the model is changing, and you'll see that the surgical mission groups are learning from our own partnerships and changing their model of care and how they're raising money as well.
Thank you. Any further?
I wanted to ask how you resolve the language barrier.
So in Mozambique, they do speak Portuguese, and I speak Spanish fluently, which has been incredibly helpful. Initially, I went in thinking I need to learn Portuguese. What I realized actually, and I learned this from a very experienced colleague of mine, he said, he didn't know any Spanish or Portuguese, and he was doing really good work in Mozambique as well. He had said, it's actually important that the local physicians learn English. And so, because all the medical literature is in English, all the conferences are in English. If they want to publish a paper, it's going to be in English. And so, I still communicate to some degree in Spanish, and I learn some Portuguese phrases. But I really do encourage and push the physicians locally to learn English. And what you'll find now, especially with these partnerships that we have, all of the medical students are starting to take English. All the physicians are starting to take English. Doctors who I couldn't really communicate with very well are all enrolled in English classes. So this is, again, part of the cultural changes that we're starting to see locally.
the resident.
Out with the patients.
So, in some ways, I think that's a blessing because I'm never going to be, I personally can't live in Mozambique, because of my own family. So I want the local providers to be the local providers. And hopefully they'll be encouraged to learn the local indigenous languages, of which there are 200. So even they will have problems communicating locally with some of their patients. But for me, that's not my role. My role is as trainee, educator, facilitator.
I was just going to mention to that we have two of the residents from two of the Mozambican residents are selected each year to come to UCLA for 2 months, and they have to be somewhat comfortable with English to come. So it's been a great incentive for the local physicians because they know that they'll have an opportunity to come to LA.
Yes, sir.
Thank you each for very poignant and tear-jerking stories. And I know you've touched a little on this, but you have an audience of potentially, a captive audience of potential philanthropists, and who may give unrestricted funding to you, which is different than what you may get other ways. Can you give specific examples of what's on your wish/bucket list with these kinds of unrestricted fundings?
Thank you for that opportunity. Who wants to go first?
I can
Go ahead,
start.
Dr.
So
Coach.
I think earlier I had talked about this fellowship that we were working on developing, which would allow our trainees a year-long training opportunity in country, sort of similar to the Chris Buck story, where they can have a lasting impact on the trainees in country as well as our trainees that are visiting the area. And again, that takes, in many ways, unrestricted funds that can fund that person's salary to allow them to live abroad. And I think that would be sort of the main thing that we would be looking for.
Yeah, I'll also say that research training in global health is something that we really would like to figure out a way to do. In fact, we're trying to come up with a way of honoring Dr. Coates by creating a Coates Fellowship in global health research. And I think it would be, because we want people to go and have global health experiences, but we also want them to make this their career. And I think that it is really needs dedicated time and specific training to be able to have a career in global health. And as you can see, there are many different ways to participate in it. And my passion is for research, so we're looking for ways to fund people in infectious diseases who want to have research careers to be able to spend the time to do it.
I think for Partners for Pediatric Progress, I think the training site in Peru in some ways has been the poorer stepchild because we've not had much funding for that program compared to the PEPFAR infusion for the African program. And I would really love to be able to send more faculty members from here on a regular basis to do ongoing training in that setting. And then really the key figure, as we mentioned, is in Africa is Chris Buck, and that funding is coming to an end that we've been receiving from corporate social responsibility. So we're becoming increasingly more dependent on private philanthropy to keep him alive.
Yeah, I think, again, avoiding how many operations are we doing, having unrestricted funding would be incredibly helpful. We are currently sending and pairing up our residents with faculty to travel abroad and carry out these quality improvement projects and carry out these bilateral exchanges. And that costs money. We've received a little bit of pilot funding, which is going to run out. We also needed a little bit of administrative support to make sure that all of our trainees are appropriately trained. We have this pre-departure training to make sure they receive cultural sensitivity training, that they've received appropriate drugs in case they get a needle stick exposure for prophylaxis against HIV transmission. There are all these little costs that add up that we could really scale this up, as you point out, if we could have some more funding. Right now, we're always thinking small because we have a small amount of money.
Thank you. I believe we have time for one more question. Yes. You are the chosen one.
I'm the chosen one. Mine was not really a medical question. Dr. Miller, you mentioned that you had a visit with the American ambassador. So I was wondering about that relationship. Are they supportive of you and
fantastic,
your team?
yeah. Yeah, we've met with 3 U.S. ambassadors now, and Gene Washington, when he was the dean of the School of Medicine, was invited by the previous U.S. ambassador to go to Mozambique because the embassy wanted to really celebrate the contributions that UCLA has made to the healthcare of children in country. And the ambassador's turned over. He heard about the work that we're doing, and he asked if we could get together with us. So it was fantastic.
Yeah, second question. Are you running into French groups, English groups, Belgian groups there, or is it just Americans?
You mean other healthcare workers?
There's come from Spain, Canada, Vanderbilt University, UCSF.
The UK,
Brazil.
Cuba.
And
Cuba,
historically,
yeah.
you know, the surgeon that I worked with was trained by a Russian in part, by a British guy. So a lot of people hoping to help. And what's nice about the global health community is that it's really become quite collaborative. We're all getting to know each other as it really becomes more developed community. And we're able to partner up. And so we're trying to partner up right now with a Vanderbilt pediatric anesthesiologist. We're taking care of the pediatric surgery. Our groups at UCSF are working on other projects to make a difference.
Well, I'd like to thank you all again for attending this evening and for listening to our programs. I also like to thank our panelists one more time for sharing with us. So following the panel, there'll be a post-panel reception out in the front, and all of us will be present to answer any questions that you may still have. If you'd like to learn more about supporting our programs, there's also information in your event program. Thank you very much.